Medical pharmacology relies on the rigorous study of how chemicals modify biological systems to treat disease. It requires mapping chemical reactions from the microscopic receptor up to the entire circulatory system. The first pillar of this field is pharmacodynamics, or PD. Simply defined, pharmacodynamics is the study of what the drug does to the body. This encompasses the exact molecular receptor interactions, dose-response phenomena, and the specific mechanisms that produce a therapeutic or toxic action. The second, opposing pillar is pharmacokinetics, or PK. If pharmacodynamics is what the drug does to the body, pharmacokinetics is what the body does to the drug. Pharmacokinetics governs the mathematical reality of a chemical's journey. It measures the specific rates of absorption, distribution, metabolism, and elimination over time. Modern pharmacotherapy requires the real-time mathematical integration of both PK and PD. A physician must balance these forces to maintain a specific drug concentration within a strict, narrow therapeutic window. Before a drug can exert any effect, its target must be confirmed as druggable. This means the targeted protein possesses a physical binding pocket that a small molecule can successfully bind to. Receptors constantly balance between an active and inactive state. Many exhibit constitutive activity, activating without a drug. A full agonist completely activates the system. A partial agonist binds the active state, but produces a weaker response, displacing full agonists. Inverse agonists bind the inactive state, stopping baseline activity. Mapping this receptor affinity allows researchers to design highly specific chemical tools. However, a perfect molecular match is useless if the chemical cannot physically reach the target site in a living patient. Predicting a drug's theoretical efficacy requires solving its receptor affinity. Realizing that efficacy in clinical practice requires overcoming the body's physical barriers. Pharmacokinetics tracks the drug's journey from the site of administration into the systemic plasma and eventually to the extracellular space where the receptors reside. This journey depends on two variables. First, volume of distribution, the ratio of the total drug administered to its plasma concentration. Highly lipid-soluble drugs disperse widely into body tissues. This leaves a low plasma concentration, calculating as a massive apparent volume of distribution. The second variable is clearance. This is the rate of drug elimination relative to its concentration in the plasma. It is primarily driven by how efficiently blood flows through the kidneys and liver. The interplay between distribution and clearance determines a drug's half-life. This is the exact time required for the total amount of drug in the body to fall by 50%. Most therapeutic drugs follow first-order kinetics. This means the half-life remains a constant unit of time, regardless of how high the initial plasma concentration was. Volume of distribution dictates where the drug goes, and clearance dictates how fast it leaves. Together, these variables control the exact plasma concentration of any drug at any given moment. This chart visualizes total systemic drug exposure as the area under the curve. The peak is Cmax. The dashed line is the minimum inhibitory concentration threshold. Aminoglycosides require high initial doses to maximize the Cmax to MIC ratio. Beta-lactam antibiotics rely on maximizing the time spent above the MIC threshold. Standard drug dosing regimens are designed specifically to achieve these mathematical ratios. But these standard dosages assume the patient's underlying physiology remains stable. Relying on standard dosing models introduces a dangerous assumption, a steady homeostatic body composition. As patients age, their physiology shifts, creating a phenomenon detailed in geriatric pharmacotherapy as the kinetic contradiction. The aging process reliably produces a significant decrease in total body water, accompanied by a relative increase in total adipose or fat tissue. For hydrophilic or water-soluble drugs like digoxin, the loss of total body water shrinks the drug's volume of distribution. Administering a standard dose into this smaller volume leads to a sharp spike in initial plasma concentration, drastically increasing the risk of toxicity. Highly lipid-soluble drugs like diazepam face the exact opposite paradox. The relative increase in adipose tissue creates a vastly expanded volume of distribution. The expanded fat tissues absorb and trap the lipid-soluble drug. This drastically prolongs the drug's elimination half-life, causing extended periods of sedation or severe hangover effects in elderly patients. Biological aging rewrites a patient's internal kinetic environment. Without adjusting the math, standard therapeutic doses turn into unpredictable toxic hazards. Acute critical illness further distorts these metrics. Systemic inflammatory response syndrome triggers a hyperdynamic cardiovascular state and severe capillary permeability. As this inflammatory response progresses, patients experience capillary leak. Inflammatory fluids rapidly shift out of the bloodstream and into the surrounding tissues, creating a massively expanded volume of distribution. When standard drug doses are administered into this newly expanded volume, they immediately dilute. The plasma concentration drops well below the required threshold, resulting in clinical failure. This distribution crisis is compounded by hypoalbuminemia. Many drugs rely on binding to albumin proteins in the blood plasma to regulate their transport and clearance. In critical care, plasma protein levels plummet. Without these proteins to act as anchors, the fraction of free, unbound drug increases. This free drug easily escapes into the extracellular fluid, further distorting the calculations for clearance. Surviving these systemic distortions requires constant clinical adjustments. An expanded volume of distribution necessitates appropriately larger, weight-adjusted loading doses to ensure the initial peak hits the required Cmax. If a patient exhibits augmented renal clearance and eliminates a drug too quickly, practitioners must pivot. They reduce the time between doses or switch to continuous infusions to maintain the necessary time spent above the minimum inhibitory concentration. Pharmacotherapy is a continuous process of recalculation. Ensuring the kinetic delivery system perfectly aligns with the dynamic molecular target requires calculating variables that shift by the hour.